Hello students, I'm Dr. SJK. I'm the ENT faculty for you. I hope you all done your INICET exams in a great way. Again, it's going to be humdinger of a session where we're going to discuss all the ENT questions that have been asked in your recent INICET paper. So the number of questions that has been asked from ENT for your INICET has been on a steady rise over the years. This year is again no exception for that. Okay, let's straight away dive into the topic. We got almost 6 to 7 questions under ENT for INICET. We are going to dissect every single bit of question, every single bit of topic for you, so that you will have a clear vision when you approach your next INICET paper. Okay, first we'll start with the question from otology. This is going to be a walk in a cake question for you, because this is nothing but some are telling it to be auditory pathway sequence, some are telling it to be Bera sequence. Whatsoever, both are same. Okay, so Bera sequence is based on the auditory pathway, so you should be clear with your auditory pathway sequence whatsoever. Clear how we are going to discuss. So we got 4 options, so options doesn't matter here. See what are the components of auditory pathway. Here you have to remember the mnemonic E colima. All right, so E for eighth nerve, coli, C for cochlear nucleus, O for olivary complex, which is superior olivary complex, L for lateral lemniscus, I for inferior colliculus, then M for medial genital body, A for auditory cortex. So if you remember in this same pattern with another E added to this, E colima, you will get 1, 2, 3, 4, 5, then 6 and 7. So E proximal part, distal part, cochlear nucleus, olivary complex, these both together. So the number that I am giving here is nothing but the numbers that are the waves in Bera. Bera is nothing but brainstem evoked response audiometry or auditory brainstem response. So in Bera, we are having 7 different waves. These 7 different waves corresponds to these components of the auditory pathway. So again, it's a easy question for you. It starts with 8 now. So that would be the answer for this. Okay, starting with nuclear, starting with olivary nucleus, starting with olivary nucleus can't be the right answers for this particular question. Clear? I hope so. You understood that particular discussion. Next, we jump into the next question from rhinology. Name the nerve block in this procedure at medial canthus. Okay, the question is very specific. What is the nerve that has been blocked in the procedure given in the picture? Okay, so the procedure given in the picture was something. Okay, the procedure given in the picture was something close to the medial canthus. Okay, okay, so there are 2 versions of this particular question. Okay, one version is someone telling that they are pointing this particular area and also telling that it could be the nerve supply of external nerves. So for that people, the answer is anterior ethmoidal nerve. Okay, but what is the nerve blocked at medial canthus? For that, answer is nasociliary nerve. Okay, I'll repeat it. Some are saying that a picture was given. At that picture, there was some injection that has been given near the medial canthus. Okay, so I'll give you that particular version also. See, image showing injection at medial canthus. Okay, so these were the options according to few people. In that question, nerve injected at medial canthus was not there. Some are telling like that, but some are telling that nerve injected medial canthus, nerve word was there at the question. So whatsoever the picture given was similar to this. The picture given was similar to this. So if this was the picture, so close quarters to the medial canthus, this is our medial canthus. Just superior to the medial canthus, we are having 1.5 centimeter to 2.5 centimeter depth. We are going to inject the local anesthetic agent, means that is nasociliary block. Okay, So according to the input given by our students, it could be the answer. So what about other options? If you are telling these are the options, nasolacrimal duct syringing. So the nasolacrimal duct syringing is done at middle canthus. Okay. So if the picture given to you was similar to this, again, this could be the answer. Okay. I'll tell you again, people, if this kind of picture, like somewhat superior to the middle canthus, if this was the picture that was given to you, the answer is nasociliary nerve. If it is in close quarters to the middle canthus like this, we are checking for the patency of the lacrimal duct system. We are having lacrimal duct, we are having middle canthus, superior canalicus, inferior canalicus, nasolacrimal duct. Okay, so if we inject the needle into the middle canthus, we could check for the patency of our nasolacrimal duct. If there is regurgitation, it is block. If it is no regurgitation, it is intact. That's all. Okay. So again, according to my intuition, this could be the picture that have been given for you, because they have given this line as middle canthus. Middle canthus was given in the question. It means that they are meaning the nasolacrimal duct syringe. Okay. So what are about the other options? What is median nerve block? What is anterior ethmoidal nerve block? So median nerve is nothing but a nerve that travels through the median canal. What is median canal? Is, for example, if you are having pterygopalatine fossa like this. So from the skull base, we are having a canal called median canal. Okay. So in the median canal, we could see number 1, greater superficial petrosal nerve, and then deep petrosal nerve. Okay. Yes. If these two nerves travel together and pass along the median canal, we call these two nerves combination as median nerve. Okay. So if we are going to target the median nerve, we can't target by outside. We have to do an extensive surgery. We have to reach for the median canal just behind the maxillary bone, just at the pterygopalatine fossa. So it's not that much easy to reach the median nerve. Okay. So again, if at all, if you have to reach the median nerve, we could reach laterally, not like the middle canthus approach. So that is another option, which is median nerve block. Okay. So what is nasociliary block? That's what already discussed. Anterior ethmoidal nerve block. See here, we are having the important sensory supply of external nerves. Anterior ethmoidal nerve. Then few parts by infraorbital nerve. So anterior ethmoidal nerve is again a branch from ophthalmic nerve. Okay. So almost close to half of the external nerves has been supplied by anterior ethmoidal nerve. The function of this block is nothing but, if I have to do a nasal bone reduction, do a nasal bone reduction. So I have fractured nasal bone over here. So I'm going to introduce my Walsham's forceps. Kindly make note of it, Walsham forceps. If you're going to introduce the Walsham forceps into the nasal bone, I need some local anesthesia over this area. For that reason, I could sensitize or anesthetize the anterior ethmoidal nerve, which is useful for nasal bone reduction. So I hope I have made adequate explanation for this particular question. So you make a note of all these things. Where a nasociliary nerve comes over here. Over here, you will get nasolacrimal duct medial canthus. Okay. Over here, you will get anterior ethmoidal nerve. Okay. The video nerve is nowhere here in the close quarters, so we don't have to worry about the video nerve. Okay. So that note, we can jump into the next question. What is the diagnosis with the image given? It's an easy question where you could see some tense projection. See, it's not a fluffy projection, it's a tense projection. If it's a tense projection, it's nothing but a ranula. Okay, so a mucocele is a retention cyst. Okay, so it will not be so tense. Okay, so Ludwig's angina is nothing but submandibular abscess over the mandible area. So it has nothing to do with the tongue base. So again, Ludwig's angina could not be the answer. Dermal cyst is usually seen outside. Inside, it's very rare, but this is very pathognomonic of ranula. Or if you see a swelling over here and a swelling over the neck, it is called plunging ranula. Plunging ranula. All right, it's an easy question. Looking upon the picture itself, you could answer. You should have Ludwig's angina in your mind. It's a submandibular abscess, very, very fatal infection. It may lead to tracheostomy. It may lead to death of the patient if untreated over a matter of 3 days. All right. That note, we can enter the next question. It's a very easy question. If a thyroid swelling is obstructing the nearby structures, which structure obstruction will lead to which of the following symptom? All right. For example, I have given you the lateral view of our neck. So this is our thyroid gland. Okay. If the thyroid gland enlarges, it could compress the adjacent structure of trachea, esophagus. Then what else? Recurrent laryngeal nerve and sympathetic chain. Recurrent laryngeal nerve will be passing along the tracheo-esophageal groove over here. So CA thyroid is the most common cause for bilateral recurrent laryngeal palsy. Okay, so it's again an important MCQ. So the third one is recurrent laryngeal nerve. Then we are having sympathetic plexus somewhere over the vicinity. Sympathetic plexus. So the question is pretty simple, where if trachea is compressed, you will get dyspnea. Esophagus compressed, you will get dysphagia. Recurrent laryngeal compressed, you will get hoarseness of voice. Sympathetic chain is affected, you will get Horner's syndrome, where you will get ptosis and hydrosis, meiosis, loss of ciliospinal reflex. All right. So that's how match the following works. Clear? Now, another question. An elderly male comes with a reddish mass coming out of the nose as shown in the image. So this was the image that was given in the exams. Okay. So we are having a clue. The patient will be regularly taking a bath in the pond. Okay. Out of these four options, rhinoscleroma, rhinosporidiosis, pemphigus vulgaris, nasal polyp, the only disease that has close relation with bathing in the ponds is rhinosporidiosis. I will explain you the pathology of the rhinosporidiosis with a screenshot from our workbook. See here, rhinosporidiosis is caused by and aquatic protist and protozoa, it is Rhinosporidium seaberi. Right? It is acquired by bathing in ponds. Why it has been acquired by bathing in ponds? So the spores of this Rhinosporidium seaberi found in cow dung. So in ponds, the farmers will be bathing the cows inside the pond. Our young kids will be also playing in the pond. She will be washing the clothes in the pond. So this cow dung is released by the cow, carry the spores. That spores will enter into the nose of our victim patient. So in this way, Rhinosporidium seaberi spores, with the help of cow, entering into the nasal cavity of the patient by bathing in ponds. So where ponds are widely available in India? Southern India, like Tamil Nadu. In Tamil Nadu, we'll see in Madurai, Ramanathapuram. All right. So the most common area to get involved is nose, whereas the other areas are oral cavity, conjunctiva, gentle mucosa. So these are the other areas where it could get affected. Based on the gross appearance of this particular lesion, it could appear to be mulberry or strawberry like nasal mass. It will have irregularly studded surface. The important treatment part is surgical excision with cauterization of the base. For example, if this is the base, if this is the rhinosporidiosis mass, if you cauterize at the base now, it will avoid spreading of spores. Okay, it will avoid spreading of spores. For that reason, we are going to surgically excise and cauterize the bill. Is there any medical management is available? The medical management that is available is dapsone. So that dapsone is not it's not the drug of management, but it will help to reduce the severity of the disease. Okay, fine. Next question, a bit of CNS involved question. 14-year-old female patient presented to ENT OPD. She could understand the language and hear the sound, but unable to understand the meaning. So, poor comprehension. Okay. So, based on the ENT point of view, his audiogram is normal, Putin audiometry is normal, BERA is normal. What is the likely diagnosis? So, if those things are normal, we don't have any clues pertaining to conductive hearing loss. Otosclerosis is nothing but a conductive hearing loss, rarely sensory hearing loss, but mostly conductive hearing loss. So here no clinical picture pertaining to conductive hearing loss is given, and also it will affect females of the age group of 30 to 40 years more during pregnancy. So the first ENT option of otosclerosis has been ruled out. So what is the next thing? Michael's aplasia. What is this Michael's aplasia? I'll give you two aplasias. Okay, one is aplasia, another one is dysplasia. First one is Michael's aplasia. Second one is Montanus dysplasia. Okay, so if you come across these two terms in your question, you should never panic because it's very easy. The least severe or good prognosis inner ear malformation is Montanus dysplasia. Worst prognosis inner ear malformation is Michael's aplasia. Okay, see here, in Mondini's dysplasia, only the cochlea turn instead of 2, 3, 4, the turn has been reduced to 1.5 turns. Only the number of turns has been reduced in this particular disease, which is Mondini's dysplasia. Okay, so the patient will not have much of the symptoms. The patient will have sensory neural hearing loss, but the treatment for this patient will be cochlear implant. Okay, so it is less severe, you could treat easily. Whereas look at this, see here, we are having this black portion is our cochlea. See here, you could not see any black portion. Complete absence of cochlea, complete absence of vestibular aqueduct. So in ear, both the vestibular apparatus and cochlear apparatus both are absent. This is very severe, and worst prognosis is Michael's aplasia. So the treatment will be brainstem implant. Alright, yes. So let's jump into the other options. Whether the patient is faking, no. So if ABR is normal, it is an objective test for malingering. Okay. If in the option they have given only Puton audiometry, they have not given ABR, means you could suspect the patient to be malingering. But if ABR is normal, there is no way for malingering because it is the confirmatory diagnosis of normal hearing. Okay, so not malingering. What is this Wernicke's aphasia? It's a CNS topic. Poor comprehension, but good listening to the normal sounds. So poor comprehension, Wernicke's aphasia. Good comprehension, but irregular speech. Good comprehension, but rhythm is not good. It is Broca's aphasia. Okay, so in this question it is very clear that it is Wernicke's aphasia, just been given an option. Okay, so that completes our discussion about the questions that has been asked in INICET and the ENT. It's very easy few questions. 1 or 2 questions are very tough for you to filter upon the topics. So you just stick to your concepts. If you stick to your concepts, you could answer almost all the questions at ease. Okay, thank you for listening. Thank you.